Hello, good morning, and welcome to Musculoskeletal Diseases and Issues Part 1. We're going to start out kind of easy here. We're going to talk about sprains. Sprains are a partial or complete tearing of the ligaments that hold the bones together at your joints. Most common thing happens. The sprain goes. Maybe you fall. You sprain your ankle. I've seen people sprain their wrist. I've also seen them sprain their knee. The range of motion gets past its normal range, and there's some kind of twisting, and people have pain. For nursing students, you will see if you do some reading, they actually grade the sprains in levels. They have a grade 1, which is a mild sprain, grade 2, moderate, or grade 3. And students say, well, do I have to memorize those 3 grades? I'm going to just say to you, probably not, at least for the students I'm making this for, just but you can tell when you assess something if it's severe or not. The big thing that we want to know is how we treat the sprains. So I have an acronym here for you for how we treat sprains and a lot of musculoskeletal pain. It's RICE, R-I-C-E. So the R stands for rest. The I stands for ice after the injury and up to 24 to 72 hours. Compression, like a snug elastic bandage. We don't want to cut off circulation, and elevation. You got to remember with the ice, we only leave the ice on for 20 to 30 minutes at a time. And I want you to think about why we do that. And I can see where I've seen them talk about this when they have athletes. I've seen test questions about you found a lady at church who fell and sprained her ankle. First thing we do is keep it up off where she's not on it and rest it. And the next thing they're going to do is ice it, compress it, and elevate it after they diagnose it. Some more little details and facts about your RICE acronym. We do ice and compression immediately as soon as we can and get that part rested. These are things we want to do for this sprain. We also want to have to teach our patient about the 20 minutes out of the hour only. And if you use any kind of compression, if you have a patient and they have compression, you want to check the sensation and for adequate circulation in that extremity. This is just talking on this slide about dislocation and subluxation. Basically, a dislocation is a stretching and tearing of the ligaments, and it displaces the actual bone from where it's supposed to be. And a subluxation is a partial dislocation. And if you've ever had to be with a thing where you will probably have as a nurse, if someone has like a dislocated shoulder and they have to put it back in, it is terribly painful on the patient, and you might be giving them heavy amounts of medication. It's if you ever see one of these athletes on TV dislocate something, it's not a pretty sight to see. You do see sometimes if they have to put a dislocated joint back in, they'll have to put a patient under anesthesia. And for you, we do rest and pain control. We may be putting hot or cold on that particular joint for patient's comfort. A word you might hear in your nursing career is bursitis. It's a swelling of the fluid-filled pads that they call bursa, that are the cushions on your joints. Signs and symptoms, you get this moderate aching pain, the swelling, usually a history of injury. They go and they do a physical examination, and that's when they make the diagnosis. Another common illness or issue you might hear about is carpal tunnel syndrome. They also call it median nerve compression. It's when your fingers, you get numbness and tingling in your hands and your arm. It's caused by a pinched nerve up in your wrist. Has to do a lot with the anatomy of the wrist, patterns of when you use your hands a lot. So people who type and use computers a lot can get this. I've seen mechanics get it. It definitely requires a medical diagnosis. They can actually do surgery on this, but they prefer to just to try to get people to rest that wrist, and they also can use NSAIDs for pain. It's actually very common to have this diagnosis in the United States because we use so many computers now. So we're going to talk about fractures, and this is going to include a lot of content that students had trouble with last term. So a fracture is a broken bone. Okay, and that's just the definition of it right there. It can come from trauma, an accident. It can come from osteoporosis and metabolic problems, some type of injury that you have. It can be closed fracture where you don't see the fracture. I come in and I tell you I fractured. You see a fractured hip and you don't actually see the bone, or you can have an open fracture where the bone actually comes through the skin. Here's an example from the older textbook that we were using of some types of fractures. There's only 3 out of many types of fractures. The one on your left says pathological, which would be some kind of tumor or growth. The one in the middle says longitudinal, which see how long it is down the bone. And the one on the right, as you look at the screen, is a spiral fracture that came from some kind of a twisting motion. Here's a few more pictures of types of fractures just to kind of get you hearing some of the terminology. The one on the left as you look at the screen is called a green stick fracture, and that is usually referencing the wrist. The person put their hand up to catch themselves, and when their wrist broke, it breaks right in that location you see in the picture. The one in the middle says simple or I'm going to say just broken bone, one straight cut across the bone. And the one on the right says compound in the picture. It's where the bone is sticking through, or it's also called an open fracture. That means you go to assess them and you actually see the bone. This particular slide kind of says whatever I would just say to you, and you guys know I don't like to read to you. You know that older adults are just more at risk for fractures. They've got a decreased reaction time. They get failing vision, less agility, a lot of alterations in balance. They get a lot of hip fractures. The risk kind of goes up as you get to age 50. I think most of you are probably already kind of aware of that. So how do we treat fractures? Well, the thing we want to prevent is we want to make sure that people don't hemorrhage. And hemorrhage, you guys know they're going to go into shock if they're hemorrhaging. Okay. Our goal is to get a union back between those 2 broken ends and to get the bone back to continuity. But you're going to maybe be treating someone who hasn't been to that surgical stage yet. We want to make sure there's no shock and hemorrhage, and we want to splint it as it lies. And you say, well, what in the world does that mean? That means if I go out, I live near Route 619 in Hartville, and if I go out there and there's a car accident right now and I go and I see bone on someone that I go to help, I don't try to put the bone back. I splint it as it lies, okay? And just remember that you find it and it's all the legs really hurly-burly. You would just splint it just like it is there and get them in and let the doctors take care of that, okay? The other thing we would want to do is we would want to give a tetanus immunization. Just as kind of common when you come in after an accident. And most of these patients will be put on prophylactic antibiotics to try to prevent infection if they were injured out in the field. When out in the field, meaning out somewhere, out in the woods, or they were injured in a car accident, and we don't know what kind of bacteria or how much. If you have an open fracture, think about it. You are opening those bones to infection risk. So how do we repair fractures? So you're going to see the term reduction of fractures. So you're going to see closed reduction. That means that the bone is manipulated into alignment. We make no surgical incision. They usually are under general anesthesia, and they will either put the bone back together, possibly put a cast on. If it's like a leg or an arm, you will see a cast applied. I've actually seen cast applied without being under anesthesia too, depending on what the break looks like. The term open reduction means there's a surgical incision that has to be made through the skin and go down to the bone at the site of the fracture. Depending on the open reduction is necessary, they want to clean that area, get any bone fragments out. And then you're also going to see a term called internal fixation. Sometimes they kind of have to open someone up under surgery and anesthesia, and they have to put a pin in or something to hold the bone together. I see a pin a lot with broken hips. They'll say he has a hip pinning. They had to put a pin in there to hold everything back together. And then a lot of times they end up out at some of our nursing homes. You're also going to see something called external fixation. Sometimes the bone is so shattered, they'll actually have a big metal instrument that you can see and clean and take care of that you have to watch for infection risk while they're out recovering. We also have braces and we also have traction. We're going to talk about all of those. Here's a nice picture of a synthetic leg cast. Some casts are still made of plaster. These are usually some synthetic material that you help wet and they wrap it around the broken leg. Here's a picture of a walking boot. If a person's allowed to bear weight on an injury, they sometimes will put a walking boot on and not I've seen a walking boot versus a cast. So to go with your information on cast, the first thing I want to talk about is neurovascular checks. When you go in and you have a patient who has perhaps they have a lower left leg cast. When you go in to do vitals and do like an hourly check on them, you would also do a neurovascular assessment. You're going to check that leg that has the cast. You're going to go down to their toes. You're going to ask them if they're having any pain. You're going to reach into the edge of that cast and see if you can feel the pulse. You're going to see, do you see pallor? Are you going to check for cap refill? You're going to ask for paresthesia, and then you're going to ask about paralysis. I always start with, can you wiggle your toes? I'm going to put my hand down here, and I'm going to feel the pulse down here. And I cannot believe the amount of students who did not understand this concept last term. I'm giving you a picture here. There's a common one I've seen posted off and on the internet of a way to remember it, but it's kind of a thing, and you know what your normal are here. Is it normal to have pain after you have a broken leg? Well, of course, but this is pain that goes outside after they've been medicated and the pain is getting worse. And this is pulse. We know that they should have a pulse down in down where you can put it down by your toe, you can feel a pulse. You know that they shouldn't be pale, and you know they shouldn't be numb or tingling or complaining that there's a paresthesia and down in that leg. And this is something that you have to pick up on assessment. We are assessment collectors. I tell all you guys that we're data collectors. This is something very important. I actually have student nurses where I picked a patient with a cast or they've had a broken leg repaired, and I said, what did that leg look like? And they look at me and I can just hear crickets. I need you not to be that way. I need to put the crickets away, and I need you to think about if you have somebody with something going on in a limb, it could be an arm too. They have an arm cast or a leg cast and you didn't check that arm for these 5 P's, you didn't do your job. I need you to take a look in whatever text you happen to be using and your online resource and make sure that you understand cast care basics. The cast is either made of plastic or fiberglass. We're trying to mobilize the bone in the joint. The cast needs to be elevated. And when a patient is bed, you need to elevate that leg. If it's a wet cast, you need 24 to 48 hours for it to dry. The synthetic ones actually dry in 20 minutes, and you have to be really careful that you don't get your fingerprints and put any pressure on that tissue underneath that cast. Always use your palms until you see the cast is dry. We want to make sure all sides of that cast get dry, so you can kind of turn that leg a little bit with some pillows. You can put a cool setting on a hair dryer to dry a plaster cast, but I would not recommend that. And then people want to stick pens and pencils down in there. They are not to stick anything down in their cast to itch. It will get stuck. You'll see the cast change color. It's usually a dull color. It gets kind of shiny once it gets dry. And we need to explain all this to patients, because a lot of times a kid has a cast. He sticks a hanger or something down in there. You can do a lot of damage when you do something like that. So we did talk. The term internal fixation is when a physician stabilizes a bone with a pin, a nail, a screw, or a plate. It's very necessary to do this in fractures with older people whose bones are very brittle and they're probably not going to heal properly. An example that you might see for a patient is open reduction. It'll say open reduction internal fixation, and they abbreviate ORIF. Nurses will say he had an ORIF of his hip. So what they do, they make an incision, they put the fracture, realign the bone, and they secure that bone back with this pin or screw or nail. A lot of times they'll put a drain in. Sometimes there's a prosthetic implanted. That would be like a total hip, and there's more blood loss. Sometimes people actually get their own blood back after surgery. A lot of times these people are on IV antibiotics because we're very worried about infection in bone. You want to make sure that if it is a leg, it comes back, it's got good alignment. We want to make sure all those complications that you learned in fundamentals about immobility kind of come up and they kind of flare up again, including a skin breakdown and pain control. Here are some nice examples of what they can do with internal fixation. They can do a rod, they can do pins, they can do wire. So let's talk about external fixation for a little bit. An external fixation of a fracture is when they take a device, has a sturdy external frame, and there's pins attached to it to go in, especially when they have bone fragments. So I have a picture here of an external fixator on a lower leg. And if you look here, there's a large bar, and you can see there are 2 points where I have drawn an arrow where this fixator goes into the bone. And this is somebody that's had a like probably a motor vehicle accident where they had like the bones were just crushed and they can't set it inside with a pin. And this fixator is going to be on this person's leg possibly for I'm going to say 6 to 8 weeks, maybe. And here's the issue that we come up with that I don't think students understood last term. That fixator metal is going into the bone, and we have suddenly opened this person up to a risk for infection. We have to clean those sites, and we use sterile technique to clean those. I know sometimes, oh, nobody does anything sterile, Mrs. Weil. Yeah, you do. That is going in. If that was my loved one, I want you to clean that sterilely. We clean it usually every shift with peroxide and normal saline, and you only use like one sterile Q-tip each time. You want to go around and make sure, because these sites will start to ooze a little bit, and we got to make sure we don't introduce infection into this bone. The other thing is, don't use that piece of metal to pick that leg up. And I've seen students go to grab it. We don't grab that at all. If we have to lift this leg, you and I are going to have to hold our hands together underneath and just lift the leg straight up with our palms. And I will tell you, those fixators, they're very, very heavy. Make sure that you understand nursing management about this pin site care. So you might have to pre-medicate them for pain if you're doing pin site care. It is sterile. It's usually done with a swab with normal saline and peroxide, sometimes we cover that pin site with like a little sterile gauze. A lot of times they will let these people shower. Because remember, they're going to go 8 weeks, possibly 8 weeks with this external fixator on. At some point, they're going to have to be wheeled in and have it covered up and have their hair washed. A lot of times, they're sent out to facilities for rehab, for physical therapy, and help with their activities of daily living. So let's talk a little bit about traction. Traction is the application of a mechanical pull to a part of the body to extend and hold the part in a certain position when a person is immobile. Applications of traction, if they're severely injured, there'll be skeletal traction with what they call an external fixation. It doesn't have any anesthesia. It's a good temporary measure if the patient can't go to surgery right away. And I'm going to show you a picture here to kind of show you what this is if you've never seen it. So I want to talk about common types of traction. Okay, I want to particularly talk about the one on the left on your screen that says Buck's traction. Okay, and Buck's traction or Buck's extension is a simple skin traction used to treat muscle spasms and to straighten the leg and fractures of the hip. It's for preoperatively before they go and take them to surgery. An example would be someone's been admitted and maybe they're waiting on an okay to take them to surgery for morning, and they'll send them to you in traction. And traction has to be put on a special kind of bed. But I want to talk to you about the rules of traction because you need to understand. Where I have circled with red, I'm on the end here, I circled it, and there is actually a weight here, right here where I'm putting the arrow. It's usually a 5-pound weight, and the weight is not to touch the ground ever. And think about this. People always slide down in bed anyway, and now we just stuck a 5-pound weight on their leg. The goal is to keep the leg from externally rotating. When the hip is broke, the leg will just kind of flop, and we want to kind of help with their pain. We're going to do our 5P neuro check here, okay, guys? I need to go down here, and I need to take a look here, and I need to unvelcro here, and I usually take a look down and make sure there's no skin breakdown. So if you weren't really good at your fundamental skills, you're going to miss a lot of stuff here when you learn to think about Buck's traction. I make sure they have good capillary refill, there's no pain, no pallor, they wiggle their toes. I have to make sure that this weight is not on the ground ever, and I don't remove any of this traction here. So this is what comes up. This person cannot get up and go to the bathroom, so they're using the bedpan, or they're at risk for skin breakdown. They're at risk for immobility issues that are just the fundamental concepts of all nursing. If we have to pull them up in bed, You need someone to keep this leg straight and this weight from not flying around all over the end of the bed. So, I could pull them up, but with a draw sheet, but I would need someone to keep track of this weight for me. Hopefully that makes sense to you. The second traction is used a lot with kids. It's called Russell's. It's kind of the same principle. I don't do a lot with peds, but it is here. They do have an old thing they used to do called a head traction. I haven't seen this in a long time. I did see it on a commercial for one of the orthopedic hospitals where they had a kid with a broken bone and they wanted to let him sit up and they had him in this type of traction. But notice the same principles apply from Buck's traction to all of these other tractions. So on your left, you're going to see pelvic traction. There's a pelvic belt. Would be somebody with pelvic fractures. I actually don't see that a lot anymore. The one on the right I have seen. It's called balance suspension. They have a Thomas splint, something they call a Pearson attachment. They're actually treating a fracture of the femur and pelvis. And they use these weights for counterbalance. This would be somebody that they probably the little piece that it holds the leg up is called the Pearson attachment. And this would be someone that they couldn't quite take to surgery just yet, perhaps like after a motor vehicle accident. So here we're going to start and we're going to talk about complications of fractures, and this is something that like every nurse knows. Okay, the sooner they fix the fracture, the less likely is a chance for complication. We want to continue to and look for abnormals so we get a strong, good union in that bone. First complication is osteomyelitis. It's a bacterial infection of the bone. It has a sudden onset. There's usually severe pain, tenderness at the site. They get a high fever. You'll see the adjacent tissue is soft. They can get a headache. A lot of malaise is involved. Bone is really difficult to heal when it gets infection in it. So this is something to keep in mind. This is probably a new vocabulary term to all of you also. If someone is diagnosed with osteomyelitis, their antibiotics may be prescribed for 4 to 6 weeks. If there's an abscess, they'd have to go in and incise and drain. They call it an IND, to get the infection away from the bone. If there's any dead bone, they have to debride it. I would say I have seen people with osteomyelitis end up needing an amputation. So one complication of fracture is a fat embolism, and a fat embolism is not a DVD and a pulmonary embolism. That's a totally different disease process. A fat embolism syndrome is when particles of fat from the bone get into your bloodstream and block blood flow. Blockages can affect your brain, your lungs, skin, and other areas. The condition actually is rare statistically. It can sometimes not be serious, but it also can be dangerous. It also can turn severe kind of quickly. And what do you see first? And remembering that this is not DVD and pulmonary embolism, the first thing that we see is a change in mental status. Someone who was chatty and telling you about their kids and everything an hour ago, I go in and suddenly they have a sudden change in mental status. Their oxygen, when I check it, they're in respiratory distress. Their pulse ox can be as low, I've seen 70 and dropping. And I go to get oxygen to put on them, do what you're supposed to do. They're tachypnic, they've got crackles and wheezes all of a sudden in their lungs that weren't there before. Rapid pulse fever, and they have petechiae on their chest when I go to listen to their lungs. Petechiae is a measles-like rash over the chest, neck, upper arms, and their abdomen. What's happened is these little fat globules are just blocking everything in the whole entire body. So we have to get treatment and someone up to see them as soon as possible. They're probably going to need to be put to some kind of step-down unit. And there's no cure for this fat embolism. The only cure would be to repair the bone. And there's no standard treatment plan. A lot of times they're put on corticosteroids and other medications down in a unit. And they definitely need like a full oxygen mask. This isn't something that a nasal cannula is going to help with. You're going to need 100% oxygen for them. That's how quickly they start to deteriorate. It is something that you need to know and need to understand the difference between a DVT and a pulmonary embolism. So pretty clear here on nursing management. Stay with this patient. They need to go into high Fowler's position immediately, and you're going to need a non-rebreather mask. If they do not have an IV line, you go ahead and just start one. Physician or someone who can help you needs summoned right away. You need to understand they are going to give them hydration with IV fluids, and possibly they would be intubated and on mechanical ventilation.